the same points lah for the chronic phase, like all we know, but the difference is mentioned here. We see the WHO first lah. So this is actually table for the high risk CP, okay, because the chronic phase is more or less chronic phase for WHO is more or less the same for the ICC. Okay, but this is the high risk features associated with increased risk of progression in chronic phase CML according to 2022 WHO classification. So they divided into at diagnosis and also emerging on treatment. So the first one, if at the diagnosis itself, with high ELTS score, this is the features of the high risk CP. Nanti I explain high ELTS score tu apa. And the 10 to 19% blast in bone marrow or peripheral blood. So there are the asterisks here. The finding of lymphoblast in PB or PM even less than 10% is consistent with blast phase disease. And then next is more than 20% basophil in PB, also considered high risk CP. Additional clonal cytogenetic abnormality in Philadelphia positive cell, so such as second Philadelphia chromosome, deletion of 7, iso-17q, complex karyotype, and or 13q26.2 rearrangement. Cluster of small mega, including micromega, with increased reticulin of collagen fibrosis. So this is also I explain in the next slide. So on the image, the high risk CP also can be come out with the imaging on the treatment, such as failure to achieve a complete hematological response to the first TKI. I also will explain later about the hematological response. Any indication of resistance to 2 sequential TKI, development of new additional chromosome abnormality, and occurrence of compound mutation in BCR-ABL1 fusion gene during TKI therapy. So this is all the high classification under high risk CP in 2022 WHO classification. And compared to the ICC, they said they make it simple for the accelerated phase and also blast phase CML. So accelerated phase, actually the ICC criteria, all accelerated phase ada dalam WHO. So 10 to 19 blast in bone marrow or PB, more than 20% of basophil in PB, and also additional clonal cytogenetic abnormality in Philadelphia positive cells. So all of this ada dekat high risk CP WHO 2022. And the blast phase both of ICC and also WHO 2022 sama, and it will be more than 20% blast in bone marrow or PB, myeloid sarcoma, and more than 5% morphologically apparent lymphoblast warrants consideration of lymphoblastic crisis. So for kalau ada nampak more than 5% lymphoblast, it will be blast phase in ICC classification. Apparently, WHO dia doesn't mention about percentage of the lymphoblast in the its classification. So this is the difference lah between ICC and WHO 2022 latest update. Okay, so the ELTS score as per in the high risk CP, it stands for the UTOS long-term survival score. Is a prognostic tool used to predict long-term survival in patients with chronic myeloid leukemia. So it was developed based on data from adult patients with chromosome positive and BCR-ABL positive chronic phase CML. The score helped to categorize patients into different risk groups. low, intermediate, and high based on factors such as age, spleen size, percentage of blast in peripheral blood, and platelet counts. So these factors are evaluated at diagnosis before any CML therapy. So there are online calculator for UTIS long-term survival score. So as per mentioned here, kita ada age in completed years according to birthday lah. And spleen size in cm below costal margin and blast in peripheral blood, and also platelet count. So they will calculate this into the risk group lah, low, intermediate ataupun high. Okay, so another features of high risk CP is increased megakaryopoiesis, but this is rare cases. Bone marrow histological feature correlating with high risk CML. In rare cases, the bone marrow of CML show marked increase in megakaryocytopoiesis with cluster of atypical, which is MDS-like or myelofibrosis-like. So dia nampak cluster-cluster kat sini. So actually dekat high risk CP pun ada can have features, histological features like this, tapi rare cases lah. Okay. And these findings are usually associated with severe reticulin and collagen fibrosis, such as in the picture here lah, reticulin fibrosis. Immunohistochemical analysis for CD34 reveal pattern sinusoid in intravascular hematopoiesis. Increased CD34 positive myeloid precursor may or may not be documented. CD61 immunostain is positive in tight cluster of megakaryocyte. Okay, these histological features are associated with a more aggressive clinical course and poorer response to TKI. So yang ni yang tight cluster of mega and CD pattern sinusoid with intravascular hematopoiesis. So I think everyone knows already regarding the natural history of CML. So now we do have only two phase. So CML in chronic phase and CML in blast crisis. This is the summary only lah. And from normal hematopoiesis, the normal tyrosine kinase activity, the hematopoietic stem cell go to the myeloid precursor and lymphoid precursor and mature myeloid and lymphoid cell. In CML in chronic phase, there are BCR-ABL1 oncogenes as depicted in yellow dot here, and then causing a myeloid BCR-ABL1 gene specific in myeloid precursor, then cause a chronic phase in CML, the mature myeloid cell. But in CML in blast crisis, they are added with new mutation, picture as a blue dot here. And it also cause a myeloid precursor, and which is a blastic lah, and lymphoid precursor, and cause a blast tumor cell and also blast lymphoid cells in ALL and also AML. So just now I already explain about the classification. Now kita tengok dekat clinical features and also the natural history lah. And the major symptom, the majority are diagnosed in CML chronic phase, and many are asymptomatic. And most common presentation include unintentional weight loss, night sweat, fatigue, and also splenomegaly. And sometimes cause early satiety and also anorexia due to the huge size of spleen. So the FBP finding, we already know it is a leukocytosis by peak population of neutrophil and myelocyte. Absolute basophilia present and eosinophilia also common. Absolute monocytosis is uncommon, but if present, it usually associated with the E1, A2 breakdown yang I just tell you just now lah. Okay, platelet count may be increased most frequently tetapi can be normal or decreased. And unlike the myeloproliferative disorder, CML is very rarely associated with arterial and venous thrombosis. Dysplasia is uncommon in CML, but if present, should prompt consideration of atypical CML as differential diagnosis. And last but not least is normochromic normocytic anemia lah in FBP finding. So in the marrow finding, we can see the grossly hypercellular marrow with a left shifted myeloid precursor, neutrophil and also myelocyte, less than 10% of blast, increased myeloid and erythroid ratio, megakaryocyte bus with commonly seen as hypolobulated form, and increased reticulin fibers in 30% of patients, the pseudo Gaucher cell here, and also the C blue histocyte here. This is due to active phagocytic activity lah. That's why the pseudo Gaucher cell and also C blue histocytes. So in blastic phase, CML blastic phase is characterized by rapidly rising blast count and marrow failure as a result of uninhibited growth of myeloid precursor with the absence of maturation or differentiation. So in the chronic phase, this still ada maturation to neutrophil lagi, tapi yang ni dah absence of maturation or differentiation. So morphologically, CML blastic phase is indistinguishable from other cases of acute leukemia. 70% of cases of the blast or myeloid lineage by morphology and immunophenotype and may express antigen associated with granulocytic, monocytic, mega and erythroid differentiation. Aberrant expression of lymphoid marker is common, CD7, and blast in the remaining 25 to 30% of cases usually express lymphoid antigen of B lineage. Aberrant expression of myeloid antigen in CML lymphoid blastic phase is also quite common. Although mixed lineage leukemia is rare, most cases bear T Philadelphia BCR-able lesion, and these cases are recognized as separate entity lah and make up less than 1% of acute leukemia. Okay. So ini just diagrammatic representation of the CML blast crisis, myeloblast and lymphoid blast, and with BCR-able chronic phase of CML, but with the continued activity without therapy, and reactive oxygen species occur, such as DNA damage, additional chromosome abnormality will lead to CML blast crisis. Okay, now we move on to cytogenetic and molecular analysis. The diagnosis of CML rests on demonstration of Philadelphia chromosome with cytogenetic analysis or the BCR-able fusion gene with RT-PCR in the context of compatible blood and marrow morphology. So it requires both lah basically, demonstration of Philadelphia chromosome BCR-able and compatible with blood and marrow morpho. Cytogenetic and RQ-PCR offer a complementary information in both tests should be performed routinely at the diagnosis. So I made it simple. This is the table, the investigation methods lah. In CML, cytomorpho, immunophenotyping, chromosome analysis, fish, and also molecular genetic. This is the CML diagnostic according to ELN, European Leukemia Net recommendation. And first we see at the cytomorphology. So X here maksudnya need to be done lah. X kalau dash tu tak perlu. Okay. So cytomorphology, FVP lah, and also bone marrow is used at the time of diagnosis of CML. So at the diagnosis, FVP perlulah untuk at the time of diagnosis of CML, and significantly contributes to the differentiation from other myeloproliferative disease. It is it is for the staging of CML. Hematologic remission is assessed by cytomorphologic criteria during follow-up under therapy. So dekat sini perlu untuk cytomorpho and also follow-up lah until complete hematological remission. Okay, dia also perlu untuk determination of the blast percentage lah. Masa kita count tu kita akan tengok blast percentage dia berapa juga. Okay. So next is immunophenotyping. So immunophenotyping dia bukan part of the routine diagnostic. CML workup in initial diagnosis or in the remission. But it is however important in the case of blast phase to differentiate myeloid BP from blast phase of lymphoid origin. So actually immunophenotyping tak perlu pun dekat diagnosis follow up diagnosis follow up, tapi dia perlu untuk differentiation of myeloid and lymphoid blast. Next is chromosome analysis. And the presence of Philadelphia chromosome, or rather a BCR-ABL1 rearrangement, defines chronic myeloid leukemia. Testing for additional aberration is indicated at initial diagnosis, treatment failure or resistant, and progression lah. So perlu untuk detection of Philadelphia chromosome detection or exclusion of additional chromosomal abnormalities at the diagnosis. Tak perlu untuk follow up, and perlu untuk for detection or to see whether there's a therapy failure or resistant. It detects the additional chromosomal abnormality. Okay, the high risk additional aberration includes trisomy 8 and 19, additional Philadelphia chromosome, aberrant KMT2A rearrangement, and also MECOM rearrangement. Okay, yang 11Q23 ni ialah KM2A and 3Q26.2 ni ialah MECOM rearrangement. And also complex karyotype lah. All other additional aberration belongs to low risk group. So dia tak include dekat high risk CP group. Okay, so next is fish analysis. Fish can confirm or exclude presence of BCR-ABL1 rearrangement within 24 hours. Using fish on interface nuclide, 100 to 200 cell can be checked for the presence of BCR-ABL1 rearrangement. Even in CML patient without Philadelphia chromosome, the diagnosis can be further confirmed by this technique. So in dekat diagnosis ni, in Philadelphia negative cases, we can do FISH lah untuk confirm the diagnosis lah. And furthermore, FISH can be used to verify the cytogenetic response to therapy in both interface nuclide and metaphase. FISH can also be used to screen specifically for certain high risk additional aberration such as trisomy 8 and 19, isochromosome 17q, and again lah deletion 7, MECOM rearrangement, and also KMT2A rearrangement. So this is fish perlu lah untuk diagnosis and also follow up. Next is molecular genetic with the methods of PCR and sequencing plays the central role in CML diagnostic. In addition to the diagnosis, detection of BCR-ABL fusion gene and determination of the transcript type. These diagnostic methods are now used both to monitor therapy response and identify resistant mutation in case of failure therapy. So for the molecular genetic, usually dia akan guna qualitative PCR to detect the PCR-ABL fusion and determination of the transcript type lah. And then perlu untuk follow up every 3 months basically untuk tengok dia punya major molecular response, and also untuk juga tengok terapi resistant for mutation analysis of ABL kinase domain, and also untuk mutation untuk if suspected lah. Okay. So this is the 5 things that we have to remember in investigating accordingly in CML patient investigation. So we come for therapy and treatment. I think I akan more specific dekat TKI. So first, fertility counselling if is needed lah for young patient who wants to have children with the question of sperm or egg cryopreservation. So fertility counselling need to be done first lah. Hydroxyurea therapy treatment can control and maintain the white cell count in the chronic phase, but it does not reduce the percentage of BCR-ABL1 positive cells. So if in the BCR-ABL detection, so this is the tyrosine kinase inhibitor lah. Imatinib is the first generation, Bosu, Dasa and Nilo is second generation, and Pona ni adalah third generation TKI. So usually dia orang akan start dengan imatinib lah. What's the standard of care for the first line treatment of all chronic CML patient after BCR-ABL1 positive was established. Nilo, Dasa and Bosutinib showed better efficacy with higher rates of cytogenetic and molecular remission compared to imatinibs. Ponatinib has a unique advantage that is effective against CML that carries the T315I mutation within the ABL. But ponatinib is associated with the highest risk of thrombotic event. So dia kena justify lah the use of ponatinib. And usually dia akan use for the T315I mutation lah. And if the TKI therapy is inadequate response ataupun resistant and intolerance, so kita kena change to other TKI and observe for the progress. And then if the treatment is failure, so we need to consider the stem cell therapy lah. Treatment option for those after standard therapy has failed include, in addition to the alternative TKI, is the implementation of the allogeneic stem cell transplant. Okay. So this is the more how we monitor the therapy response in treatment for the CML patient. So the methods for the treatment response results are expressed as percentage of BCR ABL1 divided by ABL1 according to the international scale. BCR ABL1 expression is quantified relative to a reference genes usually. ABL1 lah. So kalau kita tengok graf dekat sini, ini adalah idealized optimized reduction of BCR-ABL1 gene over duration of the tyrosine kinase treatment in years. So PCR value, this is the derived from the baseline value of a subgroup in patient of the IRIS study. And actually untuk tengok dia punya respon, after 3 months of TKI therapy, patient should have a 1 log reduction in the BCR-ABL1 to 10%. So ni masa at the diagnostic baseline. So BCR ABL1 ada 100, ada banyak lagi. So at the first 3 months after TKI therapy, kita from 1 log reduction, dia mesti 10%. And dekat 2 log reduction, which is at 6 months, 1%. 1%. And at 3 log reduction, at 12 months, dia adalah 0.1%. So bila dia 0.1% at 3 log reduction ni, dia consider major molecular response. Okay, and then dekat log 4, kita panggil dia deeper molecular response lah. Okay, log 4, 5, 4.5 and 5 kita akan panggil dia deep, dia achieve deep molecular response. Okay, after 12 months of therapy, the optimal response of MMR or BCR-ABL1 is 0.1. Deeper molecular response may follow after a variable period. MR5 or MR4.5 acts as platform for patients who wish to join TKI association studies. So this is how we monitor the therapy response lah at log reduction. So basically dekat 3 months 10%, 6 months 1%, 12 months 0.1, and deep molecular response MR4 4.5 dengan 5. So this is what I get from the article in 2022. However, it is from the French observatory data lah. The data collected at the French CML observatory database, the multi-centered cohort, the criteria for treatment discontinuation. Okay, basically they take 5 years of treatment and more than 2 years of deep molecular response. So kalau deep molecular response tadi dekat MR4 lah, MR4, MR4.5 dengan MR5. Okay. And patient who actually discontinued treatment due to optimal response, maksudnya patient yang dah discontinued treatment with observed optimal response, 31.5% relapse. And the relapse rate was higher in patient who stopped TKI more before than after 5 years of treatment, which is 52.6% versus 26%. So this result advocates caution concerning early treatment withdrawal, including with patient receiving second generation TKI. So kena justify if patient wants to discontinue treatment, so kena justify the situation dululah accordingly. Okay. So this is the definition of the hematological, cytogenetic and molecular response. So when we say complete hematological response, meaning that we see what is the parameter. So parameter dia mesti leukocyte less than 10, basophil less than 5, no myelocyte, promyelocyte, myeloblast, indifferential blood count, platelet normal less than 450, and spleen is not palpable. So this is the complete hematological response. So kalau in cytogenetic and molecular, so kita akan tengok dia ada banyak tapi dia akan tengok Philadelphia positive metaphase. And at least 20 metaphase should be analyzed. So in complete cytological response, cytogenetic response, kita no Philadelphia positive metaphase, partial 1 to 35, minor 36 to 65%, minimal is 66 to 95%, and no cytogenetic response is still present of the more than 95% of Philadelphia positive metaphase. So in molecular, macam I cakap tadi, dia ada divide into major molecular response, deep molecular response, which is MR4, MR4.5, and also MR5. Yang ni considered as deep molecular response. So macam I cakap tadi, kalau dekat major tadi, molecular response dia mesti less than 0.1. And kalau parameter lah, MR4, the BCR able transcript is less than 0.01%. Yang ni yang tadi yang kita nampak yang 1 log reduction, 2 log reduction tadi tu. And MR4.5, dia punya ni, and MR5 is 0.001 log reduction lah. Okay. Yang ni yang according to the graph tadi lah. MR4.5 dengan MR5. Yang ni yang deep molecular response 0.01 dengan 0.001. So I think that's all. That's all for my presentation. Thank you.
Saya ada soalan.
Ya.
Nak tanya pasal yang fish tu, fish untuk Philadelphia negatif tu kan. Dia tengok apa? Yang atypical CML tu. Dia sama dengan mu BCR tu. Dia lain.
Dia tengok cryptic translocation kan. So you punya
dia tengok apa? Saya tak macam sebab dia pH negatif.
Betul. Dia tengok dia punya micro kan. Ya, the cryptic translocation. Sebab kadang-kadang you punya BCA, you punya yang apa nama tu? CBA conventional punya metaphase, you punya conventional cytogenetic you kita dapat jumpa. The translocation 922 tu. So bila you pakai fish, you boleh jumpa that cryptic translocation.
Maksud dia 922 juga tapi kita cakap dia pH negatif. Macam tu lah?
Cryptic. I think so that's what I understood from the cryptic lah. BCR everyone dia memang tengok 920. Tapi yang translocation 920 tu kan ada banyak boleh berlaku kan. Banyak cytogenetic fish is negative. Betul, kita the standard kita buat cytogenetic by kalau pakai the collagen apa nama dia, CBA tu, binding assay tu. So kalau negatif by conventional binding analysis, ya Allah, kalau dia negatif dan baru kita proceed dengan fish kan. Betul tak?
So conventional
yang tu kira mu BCR tu lah ya. Yang atypical tu.
Betul. Atypical tu the mu BCR. Sebab bila you buat fish tu, you takkan jumpa 920 translocation T922 tu is supposed to jumpa dalam you punya the conventional binding assay je kan.
Betul yang major minor tu kan.
So betul. So that's why you call it cryptic translocation. Dia ada tapi you can only
tengok
reveal it by fish. Betul. Sebab fish ni pun macam sort of molecular kan dia punya finding. Sebab you takkan dapat you takkan dapat the T922 the location dekat you punya, sebab you bukan susun kromosom macam tu kan.
Okay.
Cuma kalau mu
Maksudnya kalau cytogenetic 922 cannot be detected, it's not confirmatory, is it? Like we still cannot conclude it's BCR ABL negative. Is it something like that? We still need to do molecule, the fish baru boleh confirm ke?
Betul. You
Okay,
kena buat fish.
Okay, so we still need to wait until fish result comes out lah before we conclude this patient is misdiagnosed.
Contoh cryptic translocation tu macam your E14A3 dengan E13A3.
Okay.
Betul? Yang the 13 atau 14 tu is actually the exon lah. Kalau dia dekat exon 13 then it's 13A2. Kalau exon 14 it's 14A2 lah.
Okay. Okay, thank you.
Thank you.
tapi kita still consider the diagnosis as CML with pH positive lah kan, tapi not detected by the conventional.
Dia by fish.
And the variance
Betul.
ke.
Tapi wajib buatlah fish tu. Tak boleh tinggal lah dalam CML kalau you tak dapat detect by your conventional banding analysis.
Dia buat agak fish less.
Fine. Sebabnya kalau Philadelphia negatif, dia akan jadi atypical kan? Faham tak maksud saya?
Faham.
There's like a whole new topic tapi dia bukan under
Dia pun dia dapat Philadelphia negatif kromosom tu, tapi dia still kena buat fish. Kalau baru buat fish baru dapat detect benda tu.
Tapi yang term atypical CML tu WHO dah remove kan?
betul.
Dah. Yang tu yang dah remove.
2022 kan maksud you? Dah remove. Saya rasa macam tu je kot.
Rasanya dia jadi CML with neutrophilia kan?
Bukan CML, dia MDS MPN with neutrophilia.
Dia dah masuk.
Dia MDS MPN with neutrophilia, tapi ICC still remain dia as atypical CML. And you have to have a proof that is a pH negative lah, and with dysplastic dysplasia for you to call it atypical.
Okay. Dia pH negatif. Okay. pH negatif.
Dia pH negatif and dia kena the 3 MPN gene tu negatif juga.
Negatif.
Yes.
Okay. Saya nak tanya satu lagi for CML, according to our WHO classification, the cut off for lymphoblast tu memang tak ada kan? Even like
Yes.
1-2 pun macam
Kalau 1% pun you dah boleh.
plus crisis. And then how can we confirm it's lymphoblast? Is it like we still need to do IPT? So IPT kalau blast tak banyak, they don't do, right? And is it morphologically ke atau dalam Trifine we do establish the lineage of lymphoblast? How we confirm that? Dia kata morphologically pun boleh. Kan? Tak memang
Saya rasa macam susah kot kalau macam by morpho je you tengok. I mean
because morpho can be confusing sometimes.
Yeah, exactly.
Tapi itulah sebab kita kalau dekat Ampang kan, kalau immunophenotyping yang sikit-sikit dia tak buat kan. That's why I was wondering, is it Trifine? Like Trifine usually we go for as first line we go for like myeloid punya markers kan, like 117. Is it like bila dia negatif baru kita buat lymphoid markers, something like that ke?
Rasa dekat acute panel tu dah masuk dah ada myeloid lymphoid screening kan. So boleh nampak kat situ.
Tak ada
isu dia sebab you takkan
dia tak banyak kan, sebab
kalau
even
blast dia satu je tak pusing pun elok kan. I think that's what Gita is asking.
Yeah.
Based on IHC je lah kot.
Okay, understand. Alright, okay. Thank you. Okay, thank you. Sekejap saya stop sharing.
Kita sambung ya.
Okay.
Share screen. Boleh nampak tak? Okay, Assalamualaikum and very good morning to Prof and colleagues. So my topic for today is acute leukemia. So first I will focus on acute myeloid leukemia first. So AML results from the clonal expansion